Okay, let's talk about neurodevelopmental disorders. Neurodevelopmental disorders are large and diverse group. The chapter covers those the most commonly present to psychiatry: intellectual disability, autism spectrum disorder, attention deficit hyperactivity disorder, and Tourette syndrome. Let's start with intellectual disability. Okay, about epidemiology and etiology. Key epidemiology is shown in table 29.1, which is this. Okay. Here we have the causes of intellectual disability. We have genetic causes. We have prenatal causes. And perinatal causes, in addition to environmental and medical conditions in childhood. So let's start with genetic causes. Trisomies, or large structural variants like Down syndrome, Fragile X syndrome, Prader-Willi syndrome. We have inherited point mutations like phenylketonuria, neurofibromatosis, tuberous sclerosis, Leishman syndrome, Tay-Sachs disease, other enzyme deficiency diseases. We have de novo or sporadic point mutations that can cause that, have been identified in over 700 genes, potentially all with the capacity to contribute to intellectual disability. So we have trisomies, inherited point mutations, and de novo point mutations. Okay, this is for genetic causes. What about prenatal causes? We have congenital infections as cause, like torch infections, like toxoplasmosis, rubella, cytomegalovirus, herpes simplex, and zoster, which is chickenpox. Also, syphilis and HIV. Another prenatal cause is, so we've talked about congenital infection. Another cause is substance use during pregnancy, like fetal alcohol syndrome, prescribed drugs with teratogenic effects. Another factor is is about the complications of pregnancy, like preeclampsia, intrauterine growth retardation, and antepartum hemorrhage. What about perinatal causes? We have birth trauma, like intracranial that can cause intracranial hemorrhage or hypoxia. Prematurity is another cause, which may cause preventricular hemorrhage, intraventricular hemorrhage, hyperbilirubinemia, which may cause kernicterus, and infections. Environmental factors like neglect, malnutrition, or like iodine deficiency in developing countries and so on. Poor linguistic and social stimulation can cause that also. Another factors are associated with medical conditions in childhood, like infections, like meningitis, encephalitis, head injury, of course, and toxins like lead or other heavy metals. So, this is about the etiologies and the causes of intellectual disability. Okay, so no clear etiology can be determined in at least a third of patients with mild intellectual disability, suggesting they may represent the lower end of the normal distribution curve for intellectual functioning. Specific causes are more likely to be found in people with severe or profound intellectual disabilities. So, mild intellectual disabilities, not obvious. With profound, it is more obvious, the cause, I mean. Okay. What about assessment and clinical features, investigations, and differential diagnosis of intellectual disability? We've talked about that in chapter 18, so let's continue. Okay. What about management and prognosis? So, starting from prevention and detection. Primary prevention includes genetic screening and counseling for high-risk groups. Prenatal testing like amniocentesis, rhesus incompatibility, improved perinatal and neonatal care, and early detection of metabolic abnormalities that may contribute to intellectual impairment like phenylketonuria, neonatal hypothyroidism. So this can contribute to primary prevention. So milder intellectual disabilities may be less obvious, and early detection requires the ability of teachers and family doctors to be able to identify difficulties as soon as possible. So this is about prevention and detection. That was about primary prevention. What about secondary prevention? Secondary prevention aims to prevent the progression of disability by providing compensatory education and early attempts to reduce behavioral problems. If you suspect a child has an intellectual disability, this should be discussed with either a pediatrician or a child and adolescent mental health specialist who will be able to provide guidance on local services. If you suspect an adult has an undiagnosed mild intellectual disability, this should be discussed with the local intellectual disabilities team, who may suggest an initial referral for neuropsychological assessment. About help for families. Families require information, advice, and both psychological and practical support from the time that the diagnosis is first made. Adequate time should be devoted to this. And should aim to involve the parents in helping their child achieve their full potential. Support should be ongoing and should focus on education, practical matters, and psychological support. This may need to be increased at the more challenging times, such as puberty, starting or leaving school, times of stress like bereavement or illness, and the transition to adult services. What about education, training, and occupation? If the needs of a child with intellectual disability can be met by mainstream education, this should be encouraged due to the benefits of societal inclusion and mutual understanding. However, many children with intellectual disabilities have complex needs that are better addressed in specialist schools. Later, vocational guidance should be offered. Most people with mild intellectual disabilities are able to take mainstream or supported employment, like Remploy. Okay. So what about housing and social support? Most people with mild intellectual disabilities are able to live independently, with varying degrees of social and familial support. Assessment of tasks of daily living will be necessary to ensure that people are appropriately placed. For people who with more severe difficulties, residential care may be necessary. In such cases, development of social skills should be encouraged as far as practical. So what about medical care? People with intellectual disabilities should have the same access to medical services as everyone else. Although communication difficulties and false attribution of symptoms to the intellectual disability, which mean diagnostic overshadowing by that, this mean care is often suboptimal. This means that care is often suboptimal. Extra medical care is often required due to comorbidities such as physical disability or epilepsy. Many general hospitals have specialist nurses who are experienced in the management of individuals with intellectual disabilities, admitted for medical treatment or surgery. This is in UK, of course. Okay. So, hints and tips. Epilepsy is a common comorbidity in individuals with intellectual disabilities and can often complicate assessment and management. Remember that a number of different psychotropic medications can lower seizure threshold, and that mood stabilizers, with the exception of lithium, are anti-epileptic medications. Okay. Communication tip. Collateral histories are invaluable when assessing someone with an intellectual disability. When a change in behavior occurs, it is useful to ask about what else has changed in the patient's life or their daily routine. However, the prevalence of other psychiatric disorders is 3 to 4 times higher, and so these must be excluded. So, what about psychiatric care? Given the higher prevalence of comorbid mental illness in this group, people with intellectual disabilities should have access to specialist care, usually on an outpatient, community, or day patient basis, as and when required. Because the assessment and management of psychiatric illness and behavioral disturbances in individuals with intellectual disability can be difficult, most areas have multidisciplinary specialist teams. These teams can address not only major mental illnesses like schizophrenia, bipolar affective disorder, or depression, but can also help manage autism and challenging behavior. Psychotropic medications may be indicated, however, given the common difficulties with unusual presentations, polypharmacy, comorbidities, and sensitivity to medication. There should be a low threshold for seeking advice from or referral to a specialist doctor. Behavioral therapy may be useful in the management of maladaptive or otherwise difficult behaviors, like self-injury, aggression, and destructiveness. So, this was about intellectual disability. What about autism spectrum disorder? So, we've talked about epidemiology and etiology. We've talked about epidemiology. Autism is a highly heritable condition, heritability of around 80%. A substantial proportion of this genetic risk is not inherited but arises from sporadic mutations, de novo, or sporadic variants occur from times as often in people with autism as their unaffected siblings. Rare variants in over 800 genes have been linked to autism in this manner and are thought to be the cause in around 1 in 5 cases. Common genetic variants of small effect are also thought to exist, but these have not yet been conclusively identified. Analyses of common biological processes influenced by the numerous implicated genes have highlighted range of core cellular functions underlying synaptic formation and signaling, like cell adhesion, chromatin remodeling, and regulation of transcription and translation. It seems likely that what is currently referred to as autism spectrum disorder is made up of many different sorts of disorder influencing distinct but related basic neuronal functions. Although genetics may seem far removed from clinical practice at present, it can provide clinically relevant information. For example, if parents have one child with autism, the overall risk for having a second child with autism is 10 to 15%. However, if genetic testing identifies a causative genetic variant as de novo or inherited, the risk can be much more accurately estimated at 1% or 50% respectively, if the variant is 100% penetrant. Okay. So it's according to the genetic factors that are related to the specific case. Hints and tips. Many of the genes linked to autism have also been associated with intellectual disability, epilepsy, schizophrenia, and attention deficit hyperactivity disorder. These same genetic variants can influence risk for many neurodevelopmental disorders. Communication. There is no evidence to support the claim that the measles, mumps, rubella vaccine result in autism. The small study that did suggest there was a link has since been conclusively discredited. Okay. About the assessment, clinical features, investigations, and differential diagnosis, we've talked about that in chapter 18. So let's talk about management and prognosis. Actually, no pharmacological treatment are recommended for core symptoms of autism. This is by NICE guidelines. Instead, the emphasis is on psychosocial interventions. So, let's talk about that. So, these are some psychosocial interventions in adults with autism by NICE guidelines. For everyone, they need self-help or support groups for individuals and for their families, partners, or carers. Social learning program, group or individual, should include modeling of useful social behavior, explicit statement of social rules, and strategies for difficult social situations. If appropriate to individual, the individual may need supported employment program, structured leisure activity with a facilitator, anger management, anti-victimization intervention, and crisis plan. Okay. In children, a social communication intervention that is play-based and designed to maximize joint attention and reciprocal communication between the child and their parents, carers, or teachers is recommended by NICE guidelines. Comorbid mental health problems like anxiety or depression should be treated as normal, except that psychological interventions should focus more on changing behavior than cognitions and avoid the use of metaphors and hypothetical situations, of course. Okay. So for children, this is the social communication intervention. Okay. ASD are lifelong conditions for which there is no cure. The functional impact of symptoms fluctuates in response to stressors such as change, school, relationships, employment, and physical illness. The prognosis is extremely variable, reflecting the great variability between those with a diagnosis. An intellectual quotient above 70, communicative language by age 5 years, and absence of epilepsy are predictors of better long-term outcome. So IQ above 70, language by 5, and absence of epilepsy, all of these are good prognostic factors. Some people can learn to develop strategies to work around their difficulties and make use of their strengths. However, many continue to have difficulty in finding employment or friendship and require family support into adulthood. Those with comorbid intellectual disability are unlikely to be able to live independently in adulthood. So, that was about autism spectrum disorder. Let's talk about attention deficit hyperactivity disorder. We've talked about epidemiology of that. But twin studies have shown that ADHD has one of the highest heritability of all psychiatric illnesses, at around 80% of heritability. Okay. A first degree relative of someone with ADHD has a 20% chance of having ADHD. Replicated candidate gene studies and genome-wide association studies of a copy number variants implicate variants in genes encoding dopaminergic, serotonergic, and glutamatergic pathways as influencing risk. Prenatal, perinatal, and postnatal environmental factors also modestly increase risk, like maternal smoking, alcohol consumption, and heroin use during pregnancy, very low birth weight, fetal hypoxia, perinatal brain injury, and prolonged emotional deprivation during infancy. Okay. We've talked about assessment and clinical features in chapter 18. Let's talk about management and prognosis. In children, psychosocial interventions are recommended in all cases and are used first line in children and young people with mild to moderate ADHD. And in all preschool children, we use that. Okay, so in all children and young people, everyone, we use the psychosocial interventions. Okay, this is by Nice Guidelines 2008. The choice of treatment naturally depends on the developmental stage of the child or adolescent. Useful strategies include parental education or training. So we have parental education or training. We have cognitive behavioral therapy, of course, and social skills training. Okay. For pharmacological management is the first line treatment in school-age children with severe ADHD and is second line for those with moderate ADHD in whom psychosocial interventions have been sufficient of insufficient benefit. Okay, again. So, pharmacological management is the first line treatment in school-age children with severe ADHD and is second line for those with moderate ADHD in whom psychosocial interventions have been of insufficient benefits. This is from NICE guidelines. The central nervous system stimulant methylphenidate, which is Ritalin, Concerta, or Equisem, okay, is normally tried in the first instance. So we have methylphenidate, we have Strattera, which is atomoxetine, and dexamphetamine are also licensed in the UK for the management of ADHD. Dexamphetamine, this is amphetamine, but here atomoxetine we're talking about norepinephrine reuptake inhibitor. Yeah. These tend to be used in cases where methylphenidate is ineffective or poorly tolerated. In treatment-resistant cases, the unlicensed use of bupropion, clonidine, modafinil, and guanfacine, as well as some antidepressant drugs, may be considered. So, unlicensed. Okay. This should only be done following referral to a tertiary center. Improvement usually occurs during adolescence, particularly in hyperactivity. Unstable family dynamics and coexisting conduct disorder are associated with a worse prognosis. Around 2/3 of patients have symptoms persisting into later life. Although most do not require ongoing management from adult mental health services. Children, okay, this is, okay, 2/3. Children with ADHD are at increased risk for substance use and imprisonment in adult life. However, many people with ADHD go on to have successful and enjoyable lives, with professional athletes, doctors, journalists, and actors publicly stating they have ADHD. Okay. So, that's good. Here we have a communication tip. Parents' concerns need to be addressed as well as the patients. Treatment of attention deficit hyperactivity disorder has received much media interest, especially potential side effects. Be aware of this. Methylphenidate is associated with growth suppression with prolonged use. It is only prescribed in specialist setting with regular weight and high monitoring. Drug holidays can be used to allow children to make up growth gains. Rarely, atomoxetine is associated with liver dysfunction and suicidality. Here we have a red flag. Before starting attention deficit hyperactivity disorder drug treatment, assess height, weight, blood pressure, and heart rate, and personal or family history of cardiovascular disease. When monitor these parameters during treatment, monitor these parameters during treatment. Stimulants are sympathomimetic and can suppress appetite. Another communication tip. One way to sum up management of severe childhood attention deficit hyperactivity disorder or adult ADHD is to tell patients they need both pills and skills. Pills can provide a window of opportunity to allow people to develop organizational skills they struggled to achieve before. Pills and skills. Okay. What about adults? The management of adults. Pharmacological management is first line for adults with moderate or severe ADHD. Psychological interventions such as CBT may have benefit, but little research is available yet. Methylphenidate is recommended first, with dexamphetamine and atomoxetine second line. Diversion of stimulant medication is a risk in young people and adults. If someone is actively using recreational substances, advise them that they should stop doing so before a trial of ADHD medication. If fears remain regarding diversion, try atomoxetine or lisdexamphetamine. Lisdexamphetamine is a prodrug that is metabolized to dexamphetamine by an enzyme in red blood cells. This limits the rate at which dexamphetamine is generated, reducing its potential for abuse. Here we have a red flag. Stimulant medications are often diverted if a child needs stimulant medication prescribed and there is a past or current history of parental substance misuse. The school can be asked to dispense medication or an alternative used. If a young person or adult is actively using recreational substances, they need to stop before any stimulants can be prescribed. If this is not possible, or if diversion is suspected at any point, a non-stimulant alternative can be tried. Okay. Little research has been done on the persistence of ADHD symptoms across the lifespan. It seems reasonable that symptoms might become more tolerable as people learn additional coping strategies like diaries, reminders, and so on, or modify their environment to minimize functional impairment, like get a job that requires brief bursts of sustained attention only. Drug holidays every couple of years to assess whether medication is still of benefit are probably worth trying. ADHD is often comorbid with other psychiatric disorders like bipolar disorder, depression, anxiety disorders, substance use. So ensure these are assessed and treated also. So lastly, we'll talk about Tourette's syndrome. The epidemiology and etiology, we've talked about that. We've talked about epidemiology, of course. But about etiology, it is unclear, but abnormalities in dopaminergic neurotransmission have been found. About assessment, this was taken care of in chapter 18. So let's talk about management and prognosis. Often, tics do not require treatment, particularly if they are not interfering with daily life. Tourette syndrome is very commonly comorbid with other conditions like anxiety, obsessive compulsive disorder, and ADHD. And these should be treated first. And according to standard guidelines, this is the case. You need to treat anxiety, OCD, or ADHD first. If tics remain problematic after other disorders are treated, psychological treatments should be tried first. So, like psychoeducation, habit reversal and exposure, and response prevention, and so on. If tics persist, clonidine, an agonist, is recommended first. Okay, antipsychotics can also help, like haloperidol, pimozole, risperidone, or aripiprazole. Risk for side effects should always be balanced against benefits on an individual basis. Around 2/3 of children and young people with Tourette syndrome go on to have no or very mild tics in adulthood. And that's good. So, we reach the chapter summary. Let's go there. Chapter summary. Neurodevelopmental disorders are common, particularly attention deficit hyperactivity disorder. Neurodevelopmental disorders are often comorbid with other mental disorders and epilepsy. It is important to treat comorbid conditions. Intellectual disability and mutism spectrum disorders are managed primarily with psychosocial interventions. ADHD is managed with a combination of psychosocial and pharmacological interventions. So that's it. هذا والله تعالى أعلم وصلى الله وسلم على سيدنا محمد وعلى آله وصحبه أجمعين. السلام عليكم.